Good morning and welcome from all around the world to Structural Half-Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Hospital in New York City. My name is Pedro Moreno, and I will be your moderator today. We would love to hear from you, so please send us your questions directly from the website or on YouTube. And remember, you can review all our previous cases at ccclifecases.org. And please wait a minute while I transfer you directly to the cath lab for a very interesting case.
All right, Pedro, and we welcome all our CCC Live viewers for this structural case of the new year of 2026, and we'll continue every month, which is the second Tuesday of the month. Sometime they may change, and that is where, you know, everybody knows there was a big blizzard in New York last week, and that's why things were changed. So that's where we are now, and going to show this case again. Of the 12 cases, we show all varieties of the TAVR cases, the TMVR, mitral clip, tricuspid clips, and so. So this case, again, we thank, and of course, we had a very successful, our New York Transcatheter Valve Conference on in December, and that will be again end of the year and so. So with that note, let's start our presentation. These are our faculty, which is all unchanged. Right here, Lucy Safi is on echocardiography, and our cardiac anesthesiologist is Dr. Brian Mao Nguyen. So with that note, case today, we are going to show transfemoral TAVR with 29 millimeter NAVITOR Vision valve for better hemodynamics, and I'll show part of the discussion that what are the data are on the NAVITOR at present. So this patient is an 82-year-old male which present with progressive dyspnea. Sorry, before we go, I just want to introduce all our faculty, myself, Dr. Khera, Dr. Tang, Dr. Kini, and we have our two fellows. Everybody can be seen. Should we come, maybe take the slide down so that everybody can be seen, and of course, rest of the staff and Lucy Safi on the echo, she just left. Okay, with that note, let's come back to our presentation. So this patient had a bypass surgery, AFib, and of course, also had a CVA, carotid stenosis, endarterectomy. So a lot of comorbid conditions for age of 82, but good LV and severe aortic stenosis and a good medical therapy. Creatinine is 0.7. With the rest of the biochemistry is not too bad. Looks okay. And EKG is sinus rhythm and has a cath already. We are patent LIMA to LAD and SVG to OM, but occluded SVG to RPDA, which get a good collaterals. And severe aortic stenosis, and this is we have. And actually, Dr. Safi will show the current one. This patient has a high gradient, as you see, with the valve area of 0.87. So we can show the live echo now. Good.
All right, thank you, Dr. Sharma. Yes, and live echo today is actually TEE because on the table, the transthoracic images were very limited, so we decided it's better to do TEE for better imaging. So here you can see beautiful four-chamber with normal LV systolic function, normal RV systolic function as well. His aortic valve is very fibrotic with restricted leaflet motion. All three leaflets are very restricted in motion, and he does have some central aortic insufficiency, as you could see here. In terms of his LVOT, it's not very calcified. Again, his leaflets are more fibrotic and restricted in motion. His AVA measured at 0.9 centimeters squared with a stroke volume index of less than 35. And his mean gradient was 19, peak velocity 3, and dimensionless index was 0.25, consistent with paradoxical low flow, low gradient, aortic stenosis. And here you can see not much mitral regurgitation or tricuspid regurgitation. Thank you.
Okay, beautiful. So it's more so just aortic stenosis, everything else is mild. And so this we have seen already. And now we go to our CT. So question comes down to calcification point of view, and I'll ask Sahil that is there any, at present, the NAVITOR valve is approved for high-risk patients?
Yes,
and
correct.
the trial for the low and intermediate is ongoing. And question was, when we did cases in the beginning, when there was too much calcium, we had a lot of recoil of the valve. So what is there any cutoff in the trial, Envision trial at present, that any degree of calcium is the patient not allowed to go into the trial?
Yeah, no, I think that's very important to understand because initially approved for high and prohibitive risk cases based on mostly the Portico data. And what we have seen now in the Envision trial, which is for low risk patients, bicuspids are automatically excluded. So not doing bicuspids is mostly tricuspid valve. There's no number cutoff, but there's obviously a screening committee that goes through all these cases. If you have extensive calcification, if you have extensive LVOT or annulus calcification, or if there's eccentricity in the LVOT compared to the annulus, so the cases may be rejected and not be approved. So yeah, if you have extreme amount of calcification, 7,000, 6,000, all leaflets involved, then I would be a little concerned because of lack of good recoil and under expansion. But most of your cases, whether it's less calcium or intermediate or severe calcification, I think the valve does really well within reason.
Yeah, so I fully agree with that statement, but we have seen in the beginning, we actually had few early recoils and we had to do it, but then we are more careful. And most of these heavily calcified valves, question always comes, do you put a sapien or do you put a evolute self-expanding? Sapien, of course, has a higher chances of annular rupture, and evolute will be chances of less expansion. So any preference in a heavily calcified aortic valve, Gilbert? And
yeah, I think you have to go case by case based and also operator experience, right? You know, you want to do what's right for the patient, what you're also good at. I think the balloon expander has higher radial force. I think with the ultra Brasilia skirt and all, I think that there's definitely, at least in our experience, seen less PVA versus self-expanding platform. But the NAVITOR versus Evolut, NAVITOR has the active seal, the cuff, versus the Evolut has more like a wrap, so it's a bit different mechanism to reduce the PVL. So the active seal cuff may be a little bit more advantageous. It's almost like the old Sapien 3 in terms of the way it works.
okay, all right. So Sahil, take us through this CT aorta.
Sure. So this is a reasonably sized annulus. You can see the dimensions. Average is around 26 millimeter, and your area is 536, and a perimeter is 82.9. You can see the LVOT tapers down slightly, but not much of a difference. Your average dimension is 24.6, and your perimeter is 79.6. So a very reasonable choice for either of the valves here. You can do Sapien, NAVITOR, or Evolut. So pretty not hostile anatomy for the aortic annulus. The STJ is around 29 and 30. The sinuses are pretty generous at 35 and 36. The left main height is 15.4 and the RC is 21. Remember, the SVG to the RPDA is occluded here. The LIMA to LED is patent. So yeah, RCA becomes a little bit of a point of concern because that's a patent vessel.
Okay. Okay, so therefore, by all the criteria, it fits into your 29.
Yeah, it's a good size. 29 would be the ideal size for this case.
But have you ever used 35 millimeters so far?
We have used a few 35s. Actually, we were one of the first sites to use 35 valve when it was launched, the Titan valve, and I think we've had very good experience with it. The only issue is some of these really bulky self-expanding devices, there is an element of unpredictability, and we've seen it with 34 Evolut as well as the 35. So as far as recapture also, it becomes a little challenging because these are self-expanding systems. So we try not to, but if we have to, we've had really good results.
And unpredictability in terms of could die down, or what, in terms of what?
So what usually happens is most of these cases, the LVOT is also pretty big compared to the annulus. So they tend to dive down on release just by the tension in the entire system, although the FlexNav has less tension than the Evolut system. But also, when you're trying to recapture, it may not recapture fully. You have to do a very slow recapture. So it takes time to recapture the entire bulky 35 device. So I get a little concerned and skeptical in those kind of anatomies, and my go-to would be a 29 Sapien if we can, or 26 Sapien with volume.
And Dr. Sharma, actually, in fact, I think Abbott's coming in the next generation 3510 on a little bit larger profile, so you can actually recapture more easily. So I think because there's so much constraint to Sahil's point of the capsule to compress the 35 millimeter inflow device into a 14 French equivalent profile delivery. So that's pretty hard.
Okay, beautiful. All right, let's keep going. CT aortic root, nothing unusual, right?
Yeah, there is calcification. You can see there's punctate calcification throughout the aorta. So I would call it higher risk for if you wanted to offer open heart surgery. This would have made this patient a higher risk for open heart surgery.
Beautiful. Yep. Okay, access.
Access again, the calcium in the aorta almost always extends down to the arteries peripherally. You can see a lot of calcification all throughout the iliacs and the lower portion of the abdominal aorta. So we have a good spot on the right side. You can see good dimensions there. Otherwise, not a prohibitive case for TF TAVR.
So summary, basically the 82-year-old with the high risk because of, we call it a high surgical risk because of so many comorbid conditions. Although STS mortality is 3.47, puts into the medium, intermediate, but because of so many conditions, and we selected at present the NAVITOR Vision 29 millimeter for the better hemodynamic with percutaneous femoral arterial access. Okay, show us where you are now, Annu.
Oh, yes, sir. T.
Good.
So this is the aogram. So we will cross now, right?
Yep.
Ready to cross?
So Dr. Kini, anything you worry about in this aortogram in terms of calcification? Do you decide when to predilate, when not to predilate?
Once we have, based on the echo, you've seen that, right? And also with the NAVITOR, since it's self-expanding, I would predilate first.
Okay.
Yeah.
The
Very
self-expanding
fibrotic.
valves should be both pre and post dilated or
Great question,
Mostly,
Dr. Sam,
yes.
actually. That's a good discussion point for the audience. So I think, the challenge, if it's heavy calcification, you definitely should pre-dilate because you don't want to have an infolding. That's a big no-no for any self-expanding platform, and also makes it easier to cross. But if there's not much calcium, like in this case, the calcium score is pretty low. You can see on echoes, probably not necessary. Abbott does recommend more aggressive pre-dilatation in anatomy, just so that in terms of the opening force is very different from Evolut. But I think one key takeaway that we publish in our work is post-dilatation to optimize the frame expansion. I think that debate is pretty much settled now in terms of whether we should do that routinely or not. Not because of paravalvular leak, particularly in younger low-risk patients, because there have been now more than one paper, meta-analysis included, showing mild PVL actually has an impact on mortality, maybe not in partners 3-7 years, but certainly some of the more contemporary data from Ocean Registry in Japan, from actually our paper, Dr. Kini's paper on Resilia, that mild PVL, especially in low-risk patient, actually was associated in the real world, mortality. So we're not just doing PVL, but also frame expansion, because under expansion is a precursor for early degeneration in heart.
And many of the trials have shown that post-dilatation definitely gives you the bigger effective orifice.
Yes, that's actually a paper that just showed that on the balloon expandable platform and increased EOA. And actually, following this point, that Rajbekar just came up with a paper that's showing PPM in balloon expandable valve actually now does increase mortality. So all come aside, I think, all three platforms are suitable. I think it's just what you're most comfortable with in experience. And I think you have to get the first implant right. Just like in surgery, right? We want to get the first surgery right because you don't want to have to go back so early. And so surgical valve is not immune to this issue as well.
So do we want to predilate or let it be? Let's take a poll.
I think, the way it looks like, pre plus minus, pre you can avoid, but definitely post.
Yeah. Dr. Moreno, any questions from the audience or?
So far, so good. We does have one question, which is the gradient. If the gradient doesn't correlate with the severity, and the EF is also normal. So what do we think about those comments?
Yeah, no, great question, Dr. Moreno. So as Lucy, maybe Lucy, why don't you take that question since you're the imager and you talk about
You can
severity.
talk about paradoxical low
Right,
flow
so
gradient.
this fulfills all the criteria for paradoxical low flow, low gradient, severe aortic stenosis. So the AVA was less than 1. Although the mean gradient wasn't 40, which we would expect with high gradient aortic stenosis, the dimensionless index was less than 0.25. And the index stroke volume was less than 35, which is consistent with paradoxical low flow, low gradient. And then also, when you take a look at that short axis, you can see on the initial images that I showed on T that the aortic valve leaflets are very fibrotic, which you do see a lot with patients with paradoxical low flow, low gradient. So they're all restricted and in motion. And so this is not high gradient aortic stenosis. This fulfills all the criteria for paradoxical low flow.
Yeah, that's so Lucy is absolutely right. So there's an entity called paradoxical low flow, low gradient aortic stenosis, which the aortic valve area is less than 1. So that fits the definition of severe. However, the gradient is low. So like in this case, especially on the TE where you have sedation. So you have to calculate the stroke volume index, as Lucy mentioned. And the definition is less than 35 is considered paradoxical low flow.
Yep.
And so that is something that to be mindful of. So just because the gradient is low doesn't mean the AS is not severe. So you have to correlate and calculate that extra. And that's pretty easy to do on a transthoracic echo. And Lucy and her colleague has actually published a paper on JACC case reports on how to actually evaluate aortic stenosis severity. I encourage you to read that. It's free, available online. So really understand how to diagnose AS severity based on different flow characteristics and gradient in a publication.
Yeah, and another comment here will be the calcium score of the valve, and we have on the CT tremendous amount of calcification, suggesting this AS is pretty severe.
Yeah, so other thing also I always want to say, when the patient comes for the procedure, they are dehydrated, they are NPO. Not uncommon, 40 gradient becomes 10. And because that's not their usual state. You get little fluid, 10 will become 40 again. So therefore, the same way, that when we do a mitral regurgitation grading, we don't do it on the TEE, do it on the transthoracic. Because anytime you cause any anesthesia, that of course the gradient goes down. So right now the pressure is on a little higher side. So we are talking to our anesthesia colleague to bring it down because pressure is 200. And ACT is good. What is the ACT?
It's 300.
Yeah, 300. So our goal is what, 275 above?
Above 250, above 250. And if you're using Sentinel, above 300.
300, okay.
Go ahead. So another benefit of this valve is the way it tracks in challenging anatomies, whether it's horizontal or extremely calcified aortas. It's relatively atraumatic. Let's go to our view.
Yeah.
You're good, okay. You're good. Go in a little bit. Good. A little more.
Pigtail was deep.
Good. Okay, you're good.
Now, can you give some dye so we see it?
No, hold on.
Oh,
You're good.
okay, let's take a cine.
Yeah.
Ready?
Yeah, so we start a little deep. Can we I want to change the view?
So it is the right point. Tell us the 3 markers at the level of the valve.
Yeah, so the vision markers are actually placed at 3 millimeters to the bottom part of the marker. These are mostly rings. These are not true markers. These are rings, and the top of the ring is 4.5. So sort of helps you, visualize where you want to land the valve. So you want to land the valve around 3 to 4 millimeters, and you can see we are trying to do that here. Gentle test. Okay.
Good. Just gently pull back.
I pulled back a little bit.
So let it just expand. It's going to take some time. It's a fibrotic valve, so give it some time. It'll expand.
Pull back a little bit.
Notebook. Test here. Okay, good. That's good. That's good. So you see how it takes time to expand, right? It's a fibrotic valve, so give it a second. All right, looks good. Valve is fully functional. We haven't paced at all.
Let me flow save that.
And no pacing. That is a big advantage, particularly patients with a low ejection fraction. Even pacing for 30 seconds can give rise to hemodynamic deterioration.
Okay. I actually like it. I think we can take it. There's, you can see it's slightly, it'll pivot. Once you release, it's going to pivot. So we should be okay.
the key is that you didn't miss the left, right? That's the.
Now I will use some pacing here. So pace 150. $180. $150 again.
Let me flow save that.
Hasn't
And
sir.
then
Let
120.
me flow save that, please.
Fluoro say.
Yep. Got it. Okay.
And you can leave at 120 for now.
So we
Till
need
we
to
have
look
the
at
tab
third
release. It sometimes takes a.
Pacemaker is down now, right?
No,
Off. Oh no.
Was it 120? No. Okay,
Yeah,
it's
it
off now. It's released.
Yeah, I just want the tab to be released. You can see it there. So the third tab, sometimes it gives you a
Okay,
little
now
issue,
it's released. Okay.
but
bye-bye.
once it's done, looks pretty good here. I like it. So
And you'll post dilate with what size?
26 true balloon.
Okay.
Your average dimension is 26. Not a lot of LVOT annulus calcification.
So we have two excellent questions. The
Can
first
you hold
one
the
is
sheet?
how to ensure cusp alignment using the NAVITOR valve.
Yeah, that's a great question. So there is no commercial alignment with this
Slower for a
platform
second,
yet.
make sure wires are
Right
good.
now, but I think next generation they may. But the good news is that with the NAVITOR platform is so, the cells are so big, you don't really worry about that. And the coronary access really never an issue.
Okay.
We also, you can see we don't use the cusp overlap view. The reason being is that we don't, that with this platform, the opening force is different. That tends to have a large swing and there's a lot of parallax. So because of that, you don't. It's not a. It's a way to simplify. This is what we call the frame alignment view. So we go to the kind of the free cuts view, take the parallax out, and you can see that as long as you don't miss the left. And we try to also use this view to help determine whether the catheter is
Let's take a
centered.
picture
Good,
first.
And so this is kind of our go-to view now.
So I want to do an aortogram just to show.
Yeah.
Remember, everyone was concerned about the left cusp here. So just good. That's good. You're good.
Right.
You're good. Yeah. Take a picture. So you see how it pivots and seals the left nicely. That's one beauty about this valve. It's very symmetric. So even though it looks slightly higher, but it's truly not.
Let's play it again.
We will. Let me balloon, then we'll play.
Yeah. Okay.
We'll do a nice aortogram. Yeah. Go ahead, Dr. Kinney.
Okay, may I have the floor?
Yeah.
The second question is
The pressure side.
about the experience with valve embolism into the LV. If we have any rescue maneuvers that we could avoid surgery.
Yeah, so with balloon expandable valve is very challenging. Let's just do the post-articulation, then we can comment.
Yeah.
Okay, let's just
Yeah,
focus
yeah.
on this
I agree.
point, right?
Okay, 180.
Yeah.
Go in a little with the balloon. Good.
Continue pacing. Continue pacing. Continue pacing. Get me in the pigtail.
Back up.
Back up.
Good. Pigtail, please.
Lucy, you can check your echo now.
So now let me comment on that. So yeah, so if you want, if the valve embolized symmetrical, there are very limited options. So for balloon expandable valve, there's really no option to rescue, because you cannot just drag the valve out. The self-expanding valve, you can try to snare it out of the outflow tract, because you might impinge on the mitral valve. The key is that you have to snare it past the coronaries.
Yeah.
Because the inflow of these self-expanding are bigger, right? Remember, this is a 29 inflow. So you can, let's say this valve, God forbid, you need to snare it back out, you have to go past the sinotubular junction. That's the safest location. If you can obviously go past the aortic arch, that's even better, but there's a risk of aortic injury, so you have to be very mindful of that, because remember, the outflow crowns are sharp. So you can cause injury that way. But whatever you do, clear the sinotubular junction. And then what I would recommend is perhaps use a different valve. Maybe a balloon expandable valve has more radial force, and I think that would be a better second valve to anchor versus another self-expanding valve. That would be
Push it in now.
our kind of
Pigtail may be trouble.
troubleshooting.
Yeah.
Take it out.
Dr. Sharma, any
Yeah, no,
comment?
that is true. So
Get
there
a
are some case
new
reports of
pigtail.
various other
Pigtail, okay.
techniques, but embolization is a tough situation. And many of these patients end up in going for surgery.
I don't know what was the issue.
Yeah, what happened now?
Nothing. We are just removing this. So can we show the echo in the meantime, Lucy?
Give a new pigtail.
Yeah, echo live, please, if you don't mind. And
All
the
right.
hemodynamic screen as well. And Lucy, please comment on the echo.
Yeah, so I mean, beautiful deployment. There's 0 leak, and I just got a mean gradient of 2. Here I'm transgastric. You can see that there's absolutely nothing. This is just wire-related valvular AR, but no PVL. On short axis, the leaflets were beautifully mobile. Again, no leak. Looks great. Mean was only 2.
Okay.
So
There's a problem.
looks good.
Okay, take out the wire.
Oh, it's stuck in the mitral. Yeah, that's better. Push the pigtail now. Push the pigtail.
Yeah, see that? It's getting full.
It's a very hyperdynamic LV.
Yeah.
So
Yes.
that's fine.
No.
Yeah.
Wait. Careful. Okay. That's the whole thing. Come, where's the wire?
Okay,
Very
good.
good.
So looks very good here.
it's
We'll do a nice aortogram for you.
See?
Yeah, something with the pigtail.
Nahi. Wire.
All right. Okay, Lucy, you still need echo or?
Probe is out, Gilbert.
Okay,
Yep.
excellent. So let's do that.
I want to do an aortogram
Yeah,
here.
let's do that here. We're at the free cuts view.
Yeah, while you go to the autogram, we have pretty active audience today. Now,
very nice.
question is, any advantages to measure the LVEF before you deploy the valve?
Yeah, it's good for academic purposes, but we've sort of moved away from it. Remember, patients with aortic stenosis have elevated EDPs, right? So not really routinely done. Looks beautiful. You see the deployment, the depth?
Yeah, this is the free cuts view. So it's basically 3 and 3. Actually, the right cut's even shallower. It's like around 2. So I think, in terms of conduction system standpoint, I don't think it'll be compromised. I think, overall, I think this is good.
Yeah.
I guess to expand on that question, Sahil, if you ended up with an EDP before of 35-40, what would you do? You postpone or you give nitro, or what will be the correct approach? Nitro, crusade?
Yeah, very good question, Dr. Moreno. We don't give nitro to patients with severe AS in general because of risk of hemodynamic collapse. Now, remember, EDP can be high, right? Some of these patients have severe diastolic dysfunction in setting of aortic stenosis. So I don't think that should preclude technically doing a procedure.
Yeah.
I would rather go ahead and, 50. I would rather go ahead and do the procedure.
Yeah, so I mean, in that particular case, maybe a little more careful in terms of hemodynamics. Don't let it go low blood pressure. Try to do with a less pacing at less, like 120 rather than 180, and then rapidly just deploy the valve. But I think the EDP alone will not be a contraindication, but that will be saying about the patient itself. Patient is in heart failure, So in those cases, I think the people underestimate the power of balloon aortic valvuloplasty. Those who are really dysfunctional, heart failure, clearly bedridden because of heart failure, EDP is high, ejection fraction low, just do the balloon aortic valvuloplasty not with a big balloon, just a moderate dilatation, gradient bring down from 40 to 25 or 20, and then patient will become hemodynamically better, get in shape, and then do the TAVR. So,
Yeah, absolutely. I agree with Dr. Sharma. Acute decompensated heart failure, and Sahil has been a leader in valvular heart shock in this space, and it's very challenging. It's very, and the problem also with TAVR, especially let's say you use a balloon expander, you have to rapid pace. So patient already decompensated and you rapid pace, they can actually tip them over, and we've seen some of those cases, and then they have a very hard, prolonged recovery. So Dr. Sharma is absolutely right. You BAV them, bridge them, not so much to decision, but actually to actual definitive intervention until they come back more electively.
Okay, their question was you have high EDP, then you decide whether it is low EF or normal EF.
Yeah.
If it's normal EF, high EDP, you proceed with the TAVR. Low EF, that's the decision you have to make before the patient comes to the room.
Yes, may optimize a little bit more, but remember, diuresis is also so limited when you have outflow obstruction that your diuresis may not work. So I would still proceed with TAVR, honestly. I think that's what you have to do in these patients.
No, there are other comorbidities. There's a lot of other comorbidities. Then, decide before you bring the patient to the room that you'll just do a BAV if the low EF condition, let the patient recover, and then do the TAVR.
That's exactly what I meant was that those kind of cases are totally decompensated. There's no reason to rush for the TAVR. Yeah, manage them medically plus minus balloon aortic valvuloplasty and then do the TAVR. Because it has to be good. We actually, when we wrote down our review article on the choice of the TAVR valve in JAMA Cardiology, we did mention that patient with a low ejection fraction. You don't want to do a balloon expandable because of the high pulse, you have to go to 180, and even that 30-40 seconds put patients in an acute hemodynamic compromise. But at the same time, if you prepare them well, we have done in a low EF many balloon expandable valve also. But key is that these all are, particularly now with the NAVITOR, is a very nice solution for that time. That here you have to either no pacing or very low level pacing of 120, 140.
Yeah, the reason why we pace is because patient is a normal ejection fraction. Yeah. If it's low, we wouldn't even need to pace, actually.
Good. Going along with the NAVITOR, another question, what is the risk of halts or LVEF, left bundle branch block, with this valve?
Yeah. So halt actually very interesting. They're all self-expanding valves. This is intra-annular. The halt is lower compared to the balloon expandable. It has been shown. Even valve thrombosis, everything is much lower. And similar data. But point is, NAVITOR, we don't have a data beyond 1 year. 1 to 2 years, some case reports, but even outside registry, Portico NG is just 1 year data. Now we are getting it. So we don't have 3, 4, 5 year data on the NAVITOR yet. Because of, we have with the Portico, the old one, but
only the Portico have 5 years. That was just recently published.
Yeah.
Okay.
And Portico is now, no longer available, but NAVITOR is not yet. But to me, it probably will be the same. If you take a 5 year of your partner, 3, and then you take a evolute 5 year. Clearly, the valve thrombosis halt or slightly higher compared to surgery in the partner group with a balloon expandable, but in the evolute trial is not higher. So with that note, let's come to our presentation.
Yeah. One more question. It says, what about this valve for bicuspid? I mean, without the 35 millimeter that you already comment that we don't do.
Yeah, so I would say that the trial exclude the bicuspid, or there is a registry of bicuspid?
No, it's excluded. So, yes, bicuspids have been used. We have data from Europe, for sure, in the Portico. We have used bicuspids off-label in certain conditions, but there are different types of bicuspids, right? Extreme calcification bicuspids, I would be reluctant to use this valve because of the opening force itself. But most bicuspids, if they are appropriate for self-expanding platforms, I think you should be able to use it.
Yeah, leaflet versus annular type 0-1 Sievers classification, okay, 2, and so that's where the trouble happens.
Yeah, the key is that you have to pre-dilate and post-dilate. I think in those cases, not just for PVL, but a lot of the failure because of frame under expansion.
So in summary, stay away or do it?
No, if appropriate case, question comes, very simple. I would say the bicuspid cases have been done in all the trial, in the partner as well as in the evolute. Yeah. They've been done, but they are more of a registry group. Now, dedicated randomized trial has started or being planned by Raj Makkar, which is they have the whole funding, and they're making it a low risk, irrespective of the age. I think age is like 50. Now, we also know once you have a low risk, 60 to 75 years of age and low risk, all comers, those patients, the bicuspid group did worse compared to surgery because of higher CV and higher mortality. That was the Notion 2 trial. So selected bicuspid can be done with resultant slightly higher PVL and maybe some residual gradient, but definitely the PVL in bicuspid will be higher than tricuspid valve. But to say that bicuspid, most of I would say the TVT registry, about 10 to 12% cases are bicuspid at present, which are getting the TAVR.
Yes.
Fantastic.
Yeah. Okay, let's go to our presentation now. So I'll go quickly to put it on our time. Go to the presentation, please. So basically just to the recent data on the TAVR field.
Also the antiplatelet, anticoagulant strategy here.
Very simple. Used to be aspirin and clopidogrel for 3 months, but recent European guideline has eliminated clopidogrel.
Correct.
You know that. But American guideline has not eliminated yet. So we still continuing 3 months of clopidogrel. But I think if you have any case with a little bleeding issue, take away the clopidogrel completely and keep aspirin. Only one disease in our cardiology where aspirin alone is good enough. Alone, everywhere else aspirin is bad. But only one condition in the valve, aspirin alone is good enough.
And it's from the popular TAVR trial.
Yeah, at popular TAVR trial. So that's why the European guideline has now aspirin only, but we are still continuing clopidogrel for 3 months. Now, what I'm going to show, a few of these publications, 2 of them leading to our NAVITOR with Portico NG and the US results of the NAVITOR valve just presented 30-day. Then Notion 2 trial, then TVT registry update of the low-risk TAVR in USA, and then valve when you have a transcatheter surgical valve degeneration, reintervention. What is the data? So one is, this is what I presented that before also. This is the Portico NG from Europe, Australia, and some cases US, 30-day and 1-year outcome of the NAVITOR, and showed very good valve area 1.9, and PVL, as you can see here, less than 3%, great success, mortality 0. And that's very, very interesting data they have. And then we go to the real life world experience from the USA on the both 2 types. They start with the NAVITOR Classic and NAVITOR Vision, and that's what happened with everyone. You start with the Sapien 3, Sapien Ultra, Sapien Regilia, core valve, evaluate FX, FX Plus. So that's a good advantage that all these companies put their energy and in making the valve better with the better outcomes. And basically showed here the elective versus a NAVITOR valve, the classic versus Vision. Not much different actually. I thought the Vision will be slightly better hemodynamics and so didn't show because all as such. There are very good data, and I'm sure with a better able to advance it, and the transcatheter with the 30-day outcome were identical with the new valve. So new valve, old valve is the same.
There is a question with the previous slide. Actually, you answered with the previous slide, which is for small valves, the NAVITOR. I can say 23-11%, no?
Yeah.
So it can be used for small valves.
Yes, that is
that's
correct.
a question. Yeah. I'm sorry, but you go ahead.
Absolutely. No, that is true. So small. The key is once you have a small annulus. I know the data we have, the balloon expandable will be better, smart trial, and so balloon expandable will be better hemodynamically. The self-expanding will be better than balloon expandable. So therefore, once a small valve, until proven, there is some reason for it, you try to go with the self-expanding or intra-annular, you'll get a bigger area. Complication no different, and PVL less than 2%. Nice valve area. One thing very important, that overall when the trial started, there were very high incidence of pacemaker. As you can see, they're almost 20%. But then with experience goes down. So what they have it, that if you did 20 more cases, then your pacemaker rate with a newer Vision valve goes around 10%. And what is our number? It's about 10, 12?
10, yeah.
So 10, 12%. It will start with almost 20%. So the one negative of this valve is definitely higher pacemaker rate, maybe similar to Evolute FX Plus, but even that is like 7-8%. This is about 10%. And clearly we know Sapien is about 3% or so. So this puts it together. Good valve, 30-day data, just to say that now we have only up to 30 days so far, 1 year from the Europe and 30-day here. So very early data present at this time. Second is Notion 2. Remember, Notion 2 trial was the trial of the low-risk patient, 60 to 75 years of age, younger patient. They could have tricuspid or bicuspid, and then see whether surgery is better or TAVR is better, and these cases. And you can see here, this was the whole trial, which started with the the original trial, basically, initially presented the 2-year data and showed at outcome at 3 years, as you can see, remains identical. And this 3-year follow-up, TAVR versus surgery, in the 2-year, the data were against TAVR, particularly in the bicuspid group, but overall now, height of the blue bar, difference goes down at 3 years compared to 1 year when originally data were presented. And this is about the durability of the valve. Overall valve degeneration is identical but severe. The bioprosthetic valve dysfunction definitely was much higher with the TAVR, with the surgical valve versus TAVR valve. But serious or severe structural valve deterioration was identical in two. And this is the bicuspid versus tricuspid. You can see that, as I said, 1 year bicuspid, notion 2, bad. Now, because of the early days, remember if you take it after 30, 60 days, then after that, with a landmark, outcome is not different. So clearly, that after some time, at 3 years, no longer remains significant p-value of 0.4 in the bicuspid cohort, and as shown here. So therefore, what we learned, the patient age 60 to 75 with severe AS who are at low surgical risk. 3 clinical outcomes are similar between TAVR and surgery. And both procedures are associated with low rates of structural valve deterioration, need for intervention, but bioprosthetic valve dysfunction occurred a little more in the surgery compared to the TAVR valve. Then the report from the STS ACC TVT registry for the low risk patients. So we know that low risk PC, since the trials approved, a lot of low risks are being done. And this is basically the large number of patients from the original trial design, and showed that low risk now makes around 30% of the TAVR. And the mortality is less than 1% at 30 days. So this is what our gold standard now. Low risk makes about 30% and mortality is less than 1% as shown here in last few years. And also you can see what was the region is, what they also did, let's go low risk, but what about in the low risk, we have the low risk trial, partner trial and evolute. The criteria were kind of similar. So in this low risk, if you are trial eligible type of patient, so not every patient, but about 1/3 will be trial eligible, 2/3 will be trial eligible. So they compare the trial eligible low risk compared to the non-trial eligible. So basically what we wanted to see, that once you do the trial eligible, is your outcome better? Because that's the way we did our trials, randomized trial which led to approval, or is it identical? So it turns out to be the patients who, the trial eligible low risk have a lower comorbid conditions, lower heart failure, ejection fraction, and overall in terms of the electivity, you see that now general anesthesia is used still in about 30% of cases in the country. This is the latest data. And of course, cerebral protection in about low teens, 12 to 13%. And vascular, primarily the femoral, very rarely we go some other side. So key was very simple, that these are associated with the low risk. And now, few things need to learn from this trial, from this table. Not all cases, hybrid operating room, big thing going on at present, but majority of the cases are still being done in the regular cath lab, which we call it a hybrid cath lab. Because you have different circulation, air circulation, and so you make it possible, and otherwise they are done in the cath lab, not necessarily in the hybrid operating room. Now, if you take into the individual endpoints, the trial eligible versus all, there is a clearly little higher event rate, MACI, in patients who are not trial eligible. Trial eligible always have lower complications and because of comorbid conditions. So this is what the conclusion was. The 1 year outcomes among real world trial eligible patients are excellent, but adverse events are higher compared with published clinical trial data, because those are the trial eligible patients. Event rate was 1 or 2% lower death rate, lower stroke rate. Likely because of the greater comorbidity burden and the lower KCC baseline score. So data can help inform the decision and status of this patient. So basically is that, can we extend the data which we learned from the low risk trial? I would say absolutely yes. And that's what led to. Now the last one is the contemporary incidence of procedural volume of the transcatheter valve reintervention. Now we are doing, patient got the TAVR or surgery, but the more important TAVR, what happens? So what has happened is that now, as you can see, the TAVR numbers are continuing to increase, but the reintervention also continues to increase, which is expected, which is going to happen. And we know that about there are 852 centers in America which do TAVR, and around 10 to 11,000 cases are done every month. So basically, point is here that TAVR, in terms of reintervention, continue to increase, and same on the right lower side, explant. So it means now patient getting a SAVR after TAVR, so TAVR explant, which continues to increase. We have shown those data in the past, usually very high mortality in the right lower group, almost 15% and so, but that number in the latest data have come to 5 to 6%. Still, TAVR explant has a higher mortality compared to if patient would have received the surgical valve replacement at time 0. Gilbert, is they still the same?
Yeah, it's around 10%. It's better, but overall, I think that's because so few people do them. You know, like they do one a year, maybe two a year. But it's real. It's happening, but it's better. People now will publish how to do it in terms of tips and tricks as well. So I think that helps.
Beautiful. So these are the various. Now, second point basically was that reintervention, different time interval in terms of the index TAVR. So what happened is, when you do the TAVR, there is a initial blip in 3 months, 3 to 4 months, because that is usually PVL. The valve may be a little down, PVL. So most important indication is the PVL. See, the first blip happens because of the within 30 days. Then the real happen after 5 years. So usual TAVR reintervention peaks at 5 years. So we can say that patients that yes, the likely nothing for 5 years, but can, of course we know, can go up to 10 years and so. Similar data for the surgical intervention. Surgical intervention numbers are constant, and as you can see, the redo surgical procedures are absolutely constant because majority of the surgical valve are getting the TAVR. So TAVR and SAVR, that is. So in this study, annual volume of both redo TAVR and TAVR explant continue to increase, particularly in recent years. Redo TAVR is frequently performed over 5 years from the index TAVR procedure. After the first 30-day blip, future analysis to determine the appropriate TAVR reintervention strategy for individual patient is needed. So put it together. So let's go to individual. Early US experience with the NAVITOR transcatheter heart valve revealed low acute complication, improved hemodynamics, but relatively higher permanent pacemaker insertion, which declined with number experience to a cutoff is 20. Then young patients with a low risk severe AS have similar clinical outcomes at 3 years between TAVR and surgery with low rates of bioprosthetic valve deterioration. Difference in the MACE in bicuspid versus tricuspid is not significant now. Then recent TVT registry data of the real world low risk TAVR showed excellent 1-year outcome, but MACE results are higher compared to published clinical trial data. This observed difference is likely to be high because of higher comorbidity burden, lower KCCQ score and frailty. Lastly, commensurate with increasing TAVR volume, recent reports from National TVT showed increasing annual volume of both redo TAVR and TAVR explant. Redo TAVR is frequently performed either at 3 months, which I said due to PVL, or at 5 years, usually because of degeneration of the index TAVR. So 3 quick questions. Following are the results of early US experience on NAVITOR valve, except similar high incidence of PP, permanent pacemaker insertion, irrespective of the volume experience, overall low incidence of death and stroke, major vascular complications are less than 2%, moderate to severe PVL is less than 2%. So wrong is A. Clearly with the volume or with the experience number 20 plus, your pacemaker rate goes down to just single digits like 9 to 10%. Second, following statement is not true about the 3-year results of the Notion 2 trial comparing TAVR versus SAVR in low-risk severe AS patient, young patient. Primary endpoint of death or stroke were similar, significantly higher death and stroke rates after TAVR versus SAVR in bicuspid AS. Bioprosthetic valve degeneration endpoints were higher in TAVR versus SAVR group, and moderate to severe SVD were similar in TAVR. Clearly, while the B was correct at 1 year, at 3 years no longer different because of 3 times higher and now become only 1.5 times. Recent TVT registry data of low-risk TAVR showed the following except overall volume is about 25-30% of the total TAVR volume, 30-day mortality is less than 1%, general anesthesia is rarely used, and overall adverse clinical events are higher than the published clinical trial data. Clearly, general anesthesia is used still in about 30% of cases, little less than 1/3, but about 30% of cases. And there was one abstract about 3 years ago that patients who had live demonstration like us, like this case we did, they have a higher chance of anesthesia because we want a controlled situation when you are doing a teaching and so forth. So with that note, I complete my presentation for today.
Well, thank you so much, Dr. Sharma and the team, for this super exciting case of the NAVITOR valve, and thank you for joining us with this activity of the audience. Remember, this case can be reviewed as soon as today and will be seen in ccclivecases.org. Most importantly, we do our structural half-life cases the second Tuesday of every month. The next one will be February 10 at 9 a.m. See you then. Thank you so much.